to this edition of Practice and Protocol. Today we're going to be looking at another real case that has taken place, and we're going to be looking at it from the perspective of shock and shock management. I have today with me Nurse Eric Hamer. Eric, before we get started, give me a little background on your history in EMS.
Yeah, absolutely. I have a brief background in EMS with 3 years as a flight nurse. I was an EMT. A lot of my background was ICU nursing for 3 years, and then a little bit of nursing education. Very
good. Give me a little history on this call that we're going to take a look at today, and a little bit about how it illustrates shock and shock recognition in the field and shock treatment.
Yeah, absolutely. So this was an interesting scene call that was actually a gunshot wound victim, so a trauma scene call that he had multiple types of shock going on at once, and we had to kind of differentiate which type of shock was the biggest issue at the time.
Sounds like an interesting case. So you mentioned you were flying on the helicopter because this was a scene flight, correct?
Yes, yep, absolutely. Okay. So yeah, it was, we're in a metro location, but we're flying about 20 minutes out to a farming location, and we ended up landing in a field and getting this guy.
Very stereotypical Iowa, I guess. We landed in a field.
Absolutely.
All right. Well, let's talk just a little bit about shock and first of all, try to define it. Like, what are we even saying shock is?
Yeah, absolutely. I feel like it's a term that's thrown around a lot, especially when I was an EMT. Everyone's like, "Oh, he's in shock. He has shock. He's had shock."
And it was like a term that we learned as lay people incorrectly, and then maybe didn't always transition to using it correctly.
Yes, absolutely. And then on the medical side of things, in nursing, you say somebody's in shock, you get a doctor's attention for sure.
Right,
so it's very serious.
Right. So back to the question, what is it?
Yeah, it's basically inadequate tissue perfusion. So where your blood is not traveling to the tissues and you're getting that end organ perfusion. So you have organ degradation and kind of failure eventually.
Okay.
So those important nutrients like oxygen and that is carried by your blood is not getting to those tissues.
Okay. So if I, sometimes as young boys, we like to do strange things like squeeze our finger and see how purple we could make it. Is that shock then, that tissue's not being perfused?
Not for a brief period of time, but if you put a rubber band on it all day.
Okay, okay. Yeah, you know, that's something that I like to differentiate. It's not exactly the definition, but I like to think of shock as being ultimately landing in a systemic hypoperfusion state. It can be isolated to certain organ systems or body systems, I guess. But yeah, tissue perfusion with adequate oxygenation, removal of waste products, supplying nutrients, that's what we're talking about with shock.
Absolutely.
All right, very good. So we have established kind of a definition, a working definition of shock, but there are some different types of shock. Give me some examples of what our different types of shock are.
Yeah, absolutely. So I think of 4 kind of primary types of shock. There is a 5th category that we'll get into a little bit, but you have your hypovolemic shock, which I think is what's on the forefront of most people's mind, especially in trauma, is you're losing some kind of volume. That can be as simple as dehydration or blood loss or any type of thing where there's a decrease in the amount of fluid in your body to be able to get that blood flow to where it needs to go.
Yeah, I love that you brought up the trauma. I think historically we have often learned about shock as it's related to trauma, but it certainly does not have to be, and oftentimes is not related to trauma.
Yeah, absolutely.
Okay. So hypovolemia, what's another type of shock that we are identifying as a category?
Cardiogenic shock, so that's an issue with the heart, that the heart is not actually being able to get that cardiac output enough to meet your body's demands.
Okay, so we have a pump problem.
Yep.
We have a volume problem, a pump problem. What's a third problem?
We have distributive shock, which is actually broken down into a lot of subcategories. So a lot of people will just list the subcategory of the distributive shock, but that's an issue with, exactly as it sounds, distribution of that blood. So there's a vasodilation that prevents the pressure needed to get that blood to where it goes. So
very good. So hypovolemic, cardiogenic, distributive, and what's our 4th primary category?
Obstructive shock.
Obstructive.
So that's a physical barrier preventing blood from getting to where it needs to be. So tension pneumo, pulmonary embolism, cardiac tamponade, things like that.
Very good. Very good. Real quick, how about that 5th category?
So that's the metabolic shock. It's mentioned in PHTLS. it's just a metabolic derangement that's not allowing blood flow to get to where it needs to be.
Sure. Very good. Very good. Well, when we have these 4 overall, or 4 to 5 categories of shock, but then we start putting little qualifiers on them with saying compensated, decompensated, and then irreversible. How are we identifying these different, we'll say, stages of shock?
Yes, it's definitely nuanced, right? There's not these clear-cut barriers where you go from this to that, but oftentimes a guideline is compensated shock. Your body has compensatory mechanisms that enable it to get additional blood flow or additional pressure, so your heart rate is going to beat faster. Your heart's going to pump faster to meet the demands of the decreased stroke volume, maybe in cardiogenic shock or something like that, to help maintain those pressures and those end organ perfusion. Now, when your body's no longer, or your heart's no longer able to meet that demand, then you start getting into uncompensated shock. So a lot of times you see hypotension, maybe you see altered mental status, more distinct signs that something is failing at that point.
So fair to say that in compensated shock, the body has recognized the emergencies, but is doing its best to mitigate it, and it may be mitigating that through tachycardia, through vasoconstriction, respiratory rate, any number of things that your body is trying to manage this emergency. However, eventually those mechanisms start to drop off, not all at once, and eventually we wade ourselves into territory then called decompensated shock. Is that accurate?
Yes, and decompensated shock is oftentimes when people start identifying it. So the biggest failure to identify is in the compensated shock, for sure.
Yeah. And then irreversible, I think pretty self-explanatory. We've gone into a territory that we're not coming back from. I do want to. There's a little illustration that I like to use that those who have been involved in the fire service may be familiar with, that are the stages of fire growth. And I've got this illustration up, and what you'll see here is that ignition phase where a fire has started, and I don't need a firefighter for this. I don't need a fire truck or a fire hose. Anybody with some water or a fire extinguisher can put this out. In the stage 3, we're talking about this fully developed, fully involved fire. The entire house is burning, and 100 firefighters and 100 fire trucks are not putting this out. It's far too late. And somewhere in the middle, we have this growth phase, and I think that where this is what shock basically is to us in EMS, where they could have got a ride to the hospital. They really didn't need us. And then the fully developed where, hey, it's too late. We've gone too far. But in the middle, that growth stage of a fire, that's kind of what I look at as being shock, and where we can make a real difference in EMS.
Yes, yep, absolutely.
So after looking at these different categories of shock, we mentioned that there are a few subcategories, or we might even just say causes in some of the cases. And let's look at a couple of those. Starting with hypovolemic shock, we go oftentimes straight to bleeding. What are some other causes that we might have hypovolemic shock?
Yeah, so that's anytime there's a decreased amount of blood or fluid coursing through your veins, basically. So that can be as simple as dehydration, if somebody is vomiting, or it can be a scenario where somebody just isn't eating and drinking appropriately. So sometimes just chronic illness can cause hypovolemic shock, especially like kids. All of a sudden they've been sick for a little bit, they're not getting the oral intake that they normally would.
Yeah, okay. Cardiogenic shock, we recognize that as a pump failure. What's causing our pump to fail?
Yeah, it can be a chronic issue, or it can be an acute. So acute would be like your STEMI, so they're having a heart attack, or STEMI.
An MI.
Yeah, yep. MI, thank you. Otherwise, it can be chronic, like heart failure, where your fluid's just backing up, and your heart's over time, the muscles have thickened to the point of where it's not having a good stroke volume and ejection fraction. Yeah,
so a chronic cardiomyopathy, or an acute event like a dysrhythmia or an AMI, perhaps. Yeah, very good. And distributive shock. This is the one where we really sometimes hear some of the subcategories almost identified as their own category. But distributive shock, we have a vasodilation, oftentimes systemically. What's causing that sometimes?
Yeah, so the big one is sepsis. So you hear
Okay.
septic shock a lot. Some people think of that as its own category, but that's a subtype of the distributive shock. So a massive infection that's causing your vasodilation. Anaphylactic shock, that's a common one that even lay people oftentimes think of. So again, you have that systemic reaction to an allergen.
Yeah.
And then neurogenic shock, which is actually going to come up in this case today, where you have just massive vasodilation due to a neurogenic injury.
Yes, and I think that is one of the cool cases about, or the cool aspects of this case that it really illustrates is that neurogenic shock. So obstructive shock, you kind of mentioned pulmonary embolism, cardiac tamponade. Other examples?
Did you say tension pneumo? I forget. Yeah. Tension pneumo. So yeah, those are the big ones.
Yeah.
Those are obstructive those are kind of your few and far between
Sure,
cases, but
sure.
but important to mention.
Right, and certainly just as severe when it occurs.
Yes.
All right. With the understanding of what shock is and how it presents, the next question is, are we seeing it when it occurs? How do you feel about that? And again, in the pre-hospital context.
Yes, pre-hospital, we definitely recognize the uncompensated shock when body systems start failing. We're not as good about recognizing the compensated shock. And there was actually a really interesting study out of Japan that was published in 2025 that talks about the paramedics and their ability to be able to recognize shock.
Yeah, so we didn't see a lot of evidence based in the U.S., but I don't think that this is probably what we saw here in this study. Is a stretch for what was taking place in Japan. Is probably happening in the United States too, but tell us a little bit about what was found in that study.
Yes, so they were able to recognize when somebody wasn't in shock 93% of the time, which is good. And 83% of the time, also really good, they were able to clearly identify shock.
Okay.
The highest area where they could identify shock was in that hypovolemic shock, which is kind of your classic shock that you're probably coming up for a call on. So some recognition signs even before you get hypotension. If you see a large amount of blood outside of the person's body, that's a good sign that they're a little low on their fluid.
Right. I would agree. And so hypovolemic shock, they seem to be finding well. I assume cardiogenic shock, where they have these complaints and maybe we're seeing it on an EKG and very aware, or a distributive shock where they're maybe having an allergic reaction. What were the area, what category of shock were they poorest performing in?
Yes, definitely that obstructive shock. It looks like only 11% of the time that they accurately identified that obstructive shock. But that's because it is more subtle and there's no overt signs, right? A lot of times you wait till you get that chest X-ray, or you wait till you get that even a D-dimer to rule out PE or something like that. So
Sure. And one thing that I think where it really rang home to me is that reliance on hypotension as a sign. And so that for us to be able to recognize shock without hypotension puts us in that category of recognizing it in the compensated often instead of the decompensated phase.
yes, yep, absolutely. You got to really use your clinical judgment and piece together a lot of different puzzle pieces, and you can't just rely on that one piece of information that you get with that blood pressure, which we definitely sometimes watch like a hawk, right? It's like, oh, is it going to drop?
You bet. So what are some ways that we can recognize shock before the patient becomes hypovolemic?
Yeah, absolutely. So you got to look for those compensatory mechanisms that your body's doing. And one of the primary compensatory mechanisms is increasing that heart rate. So that heart rate goes up to help increase that cardiac output. And we have a tool to actually measure how severe this compensatory mechanism is, called the shock index.
Okay. Tell us about shock index. What is that?
Yeah, shock index is a really simple calculation of you just take your heart rate divided by your systolic blood pressure, and that gets you a number. So if your heart rate is 95 and your systolic is 95, there are alarm bells going off that that they're hypotensive, right? 95, you're like, we're great. But that's a shock index of 1. And we know that anything greater than 0.7, 0.7 is a abnormal shock index.
Okay, so anything above 0.7 is abnormal. When are we in critical phase?
Yeah, so critical is when you are approaching that 1. So anything greater than 0.9. So as you get closer, your systolic blood pressure and your heart rate, if they start lining up and matching or within a few numbers of each other, that's a reason to intervene right away before you do anything else.
Okay. And so we'll say, if we had that perfect 120 over 80 with a heart rate of 75, well, we're not in that category because our shock index is falling in the normal area between 0.5 and 0.7. But what implications does a shock index up in the abnormal and critical area have for us?
Yes, so that's one thing that it's a predictor of just resource utilization. So one thing that I use it for in practice is, am I going to intubate this person right away, or do I need to treat their blood pressure, treat for shock before I do any other intervention?
Okay. Here we're going to cite a piece of evidence from 2019 where shock index acts as a predictor of post-intubation hypotension and cardiac arrest. And in this study, that was a rather large study at ICU, 7 EDs and 5 ICUs, in fact, with 17,000 patients, shock index over 0.9 was really where they were seeing that major increase in post-intubation hypotension and cardiac arrest.
Yeah, absolutely. So that can be really scary because all of a sudden you're coming in to try to save the day, to try to stabilize the patient, get that airway in, and then your patient goes into cardiac arrest, and you really just did them a disservice.
Yes. First do no harm.
Absolutely.
So let's talk about this call itself. We know we're going to be looking at this from the perspective of shock and treatment of shock, recognition of shock. Tell me what you found when you got on scene out into this cornfield with allegedly a gentleman who had been struck by a bullet.
Yeah, absolutely. So gunshot to his back, so went into his scapula. On assessment, his airway was patent. He was alert and talking to us. He was breathing pretty heavily, had increased oxygen demands, but not the biggest concern at the time. He had no sensation from his nipple line down, so we knew there was some neurologic injury. We didn't know if it was full neurogenic shock yet at this point, but that was definitely on our differentials.
Sure.
Not a lot of air movement on the left side of his chest, so we assumed that there was a lot of blood filling in his chest. There wasn't a lot of blood externally, so with a traumatic injury like that, you would assume there would be a decent amount of bleeding. So
Sure.
So there was a concern for hypovolemic shock as well too.
Okay. Overall, just looking at him outwardly, healthy gentleman.
Yeah, absolutely. Yeah, 35-year-old, seemed very active. No chronic issues that we knew about or seemingly that he had.
Okay. Yeah, what we can see here then is this ultimately turns out to be the entry point where the projectile entered, and then I don't know if you were able to see this at the time, if it exited or not, but here is the bullet itself, and it's kind of lying in the soft tissue. But let's take a look inside this gentleman and look at the path that it took through his body. So.
Oh yeah, you can definitely see an injury in that left scapula. There's a hole there for sure.
So yeah, the injury here in the left scapula, I'm going to make just a little bit of a dissection, and we'll take a look at that area from the inside. So we're able to see where it came through from the left scapula. It struck a rib. Spoiler alert, it caught that big spine right in the middle on the way through, but we'll get to that. And if I look over here on the right side, we see another injury to a rib. And ultimately, we find the projectile has exited through the right scapula, and again came to rest in the soft tissue of the skin. So we can see the skeletal involvement, and however, there are some pretty important organs that were not illustrated here that also were impacted. In particular, what?
Your heart and lungs, yeah, very vascular organs where you can lose a lot of blood very quickly with an injury there. So.
Okay. Well, let's take a look at those then. So here we have gentleman's facing us, and I'll kind of put him all the way back together, but he's sort of facing us off to his right a little bit. And we'll peel back, and I'm able to see his lung here in the blue, and it should be extending all the way to the anterior chest and the posterior wall back where you see the spine, or I suppose those are ribs, but it is not. What's here instead?
So yeah, anteriorly, so closest to the sternum, you kind of see that gap where there's just darkness. That just means that it's free air, or the lung's not expanding. So there's no lung tissue getting all the way to the anterior of the chest. So air is there. Mm-hmm. And then posteriorly, closest to the spine, that darkish red, that's blood. So what's not the heart, the bulb, kind of in the middle, but towards the posterior, that's a lot of space covered up by blood.
Yeah, let's take another look at that. So here we have this gentleman is now lying supine. So we have the anterior chest here with spinal vertebrae, ribs. We noted that. If I go a little deeper down in here, we definitely have some pneumothorax in the anterior portion. Here is a whole lot of something that was definitely not there when he woke up in the morning. The blood that you mentioned. Where did the blood likely come from?
Those lungs, yeah, your lungs are very vascular organs because they have so many capillaries, so many small blood vessels, because they're trying to get that gas exchange. So you have, I think, is it 20% of your blood volume is held in your lungs?
Yeah, I've heard up to 15, 20, 25% even, depending on the person and the state, could be held in your lungs at any given point in time. So yeah, he had a projectile that flew through there and damaged those lungs, and now he's bleeding a lot in the posterior side of his chest, and has some air up in the anterior portion of the chest. However, we also mentioned a little prematurely that we were going to have some spinal involvement. And tell me here, Eric, what are we looking at?
So that's our
right now.
That's the T4 vertebrae. So your thoracic vertebrae, you can see it's just not really intact. So there's that gap right in the middle of it where you can see. Yeah. So that's an intact one. That's how it should look.
Okay.
And then you scroll up and you can see it's kind of shattered a little bit. Yes.
Yeah.
So fragmented for sure.
Yeah, that's not a good situation for him. Right down the middle of these vertebrae are the spinal canal, where the spinal cord lies and is bathed in cerebrospinal fluid. It's no match for a bullet, and certainly was damaged in this case, and probably was consistent with the findings that you had there on scene.
Yes, yep, absolutely.
We'll take one more look at that vertebrae that's been damaged here, and we can see certainly that it's in a lot of pieces. A couple other things while we're in here, I don't know if I can get to it quickly. here it is. One of the structures that we can see is the aorta coming off the top of the heart. So you can see just above the vertebrae we have two blue open areas. That's the bifurcation of our trachea, and then above that is the aortic arch as it's coming off the top of the heart. And just off the vertebrae there, we can see a little bit of bone fragment and see just how close that was to striking the aorta, at which point we would definitely have a catastrophic loss of pressure, and we probably wouldn't even be talking about this call right now.
Yeah, that's where you get the irreversible
Yes,
shock.
yeah, we're in irreversible category, definitely at that time. So a lot of interesting things going on with him. So back to our categories of shock, we saw the blood.
Yep, so your hypovolemic shock.
Hypovolemic, we
Yep.
saw some air in the chest, possible.
Possible obstructive shock if you're
Okay.
thinking tension pneumo. Yep.
Okay, and then we saw the spinal cord involvement as well.
So possibly neurogenic shock,
Possible neurogenic. All right, let's take
which
a
is a
look at those.
distributive subcategory of the distributive.
Sure.
Yep.
Yes, very good. Thanks for making that point. All right, let's take a look at those in a little bit of detail and talk about some possible treatments for them. Let's take a look at a few of the different types of shock that are possibly present that make this such an interesting case. I want to hop back over here to our gentleman, and again, we can see him from the outside and know where that bullet traversed from, but let's go ahead and look at what we have here. We know we had that pneumothorax, possible obstructive shock taking place with the treatment for that being what?
Yes, so if you can see on his left chest, you can see that there is a needle sticking out of there. So I did needle decompress this guy's chest. The indication is more than just a pneumothorax, so more than just air in your chest cavity. You're not sticking a needle in somebody anytime there's air. You actually are worried doing it for a concern for a tension pneumo. So that's where there's air in the chest or something that's causing a compression of the heart so that heart is not able to pump blood effectively. So some indications or the signs that you're looking for is the hypotension, hypoxia, increased oxygen demands, respiratory distress, obviously that tracheal deviation, which is a very late sign, but even decreasing mental status, things like that are showing that there's a real problem that needs an intervention right away.
So the obstruction is the increased thoracic pressure from that air, placing pressure on the heart, placing pressure on the vena cava, inhibiting venous return and preload to the heart is what we're trying to mitigate. Tell me about placement for this procedure, best practices.
Yes, yeah, it's always very telling looking at a CT rendering of it, but this needle is actually a little low, so we counted and it's in the 6th intercostal space. The ideal would be the 4th or 5th, just anterior to the mid-axillary line. You can see I'm right at the mid-axillary line, so had I gone just anterior of that, just by the angle of the ribs and how much they slope, I probably would have been in the 5th intercostal space.
Yeah, I agree that you know, we're pretty mid-axillary here. Had we been just a little bit forward, all of a sudden we're in the right spot. We actually looked at another case in a different one recently here, exact same placement. You're not in danger territory that we will obviously see here in a second of organs that could be involved if we truly were too low on the patient, particularly the spleen would be a major vascular organ that we could get ourselves into trouble on. But let's take another look at where this wound up. So over here, we're going to see, here's where this needle comes through, and we'll notice that that needle is kind of terminating in that pool of blood in the posterior portion of the left thoracic cavity. Tell me what happened when that was placed.
Yeah, so it was very anticlimactic. You know, everyone talks about you hear the pop or you hear the rush of air. I was actually expecting. I knew there was a lot of blood in this guy's chest just because he didn't have a lot of blood externally. So I was expecting just a huge gush of blood. So I actually kind of stepped back just so I wouldn't get blood all over my boots. And really, the needle went in smooth, and there was no major effect. He did improve a little bit, so that would be the positive effect, but no pop, no rush of air, no gush of blood.
Okay, good information to be prepared for if the next time if you have not done this procedure and anticipating that. The other thing that I want to point out is on the anterior portion of the chest, we do still have some air in the chest that appears to be isolated from where that needle terminated, and that's another a condition that can make this not a foolproof procedure. In addition to hitting a pool of blood, maybe a pocket of air that's simply trapped and can't get access to the needle. Very good. So what we're seeing here is two possible sources of shock. We see the obvious hypovolemia from the blood there in the posterior portion, possible obstructive shock from the compression of the heart and the major vessels as well. But the thing that I think that makes this case very interesting is coming back here to the spinal involvement and possible neurogenic shock. If I can land on it, there it is, right there. Let's take a look at neurogenic shock now and how that may have manifested with this patient. I do want to hop over to this illustration here, and I know from the radiology report you mentioned that the vertebrae involved was the
T4.
Yep. T4. Okay. So let's take a look here. Here in red is highlighted is that fourth intercostal nerve that comes innervated off the T4. Anything below that is not getting a message. Everything above that, put overly simplified, should still be working.
Business as usual. Yep.
Okay. All right. Well, let's see why that's problematic and how that is relevant to neurogenic shock. I'm going to bounce around here for just a second, but what I have illustrated right now that we can look at is a gentleman, and we can see his central nervous system, brain, and spinal cord are both present, and I have a few nerves highlighted. What we're looking at, if I zoom in real close, and then I'm even going to take the skin and the skeletal system away, and what we can see is there off the brain stem, off the medulla, in yellow is the vagus nerve. So we have the vagus nerve, which is a parasympathetic innervation that comes in green very quickly off the vagus nerve. We have the cardiac nerve that comes down and innervates the cardiac plexus. And that is where we get our parasympathetic tone to the heart. Now, the sympathetic tone innervated there through the spinal cord up in the region just below where we saw impact. And so we lost sympathetic drive because of the involvement with the spinal cord. How did that present to you with this patient on scene?
Yeah, absolutely. Just a quick recap with the sympathetic being your fight or flight, and your parasympathetic being your feed and breed, as you say.
Yes,
I say rest and digest.
Okay,
yeah,
either way.
absolutely. So,
but yeah, these two are constantly kind of in balance, and when one comes away, goes away, you have more of a pronounced effect from the other.
Yeah, yep,
okay.
Absolutely. So, vagling down is a common thing that people
Sure.
hear about, and so that's when your vagus nerve is stimulated and it causes a drop in your heart rate. So
Okay.
when you are only having that parasympathetic impulse going to the heart, or that innervation going to the heart, it's really going to cause this bradycardic effect. And that's what makes neurogenic shock so peculiar and so different from all the other types of shock, is that you'll actually have bradycardia as opposed to tachycardia as a compensatory mechanism.
So something unique that could throw us off in neurogenic shock is that we may not see that elevated 140 heart rate compensating for the lack of basal tone.
Yeah, yes, absolutely.
Let's look at some of the vital signs that you found with this patient. And on this baseline set here, right away, we see his heart rate of 70 with a pressure of 84, over 62. I first of all want to talk about shock index. We're in shock index approaching that critical category here, but in the presence of neurogenic shock, what's possibly the explanation for what's taking place?
Yeah, absolutely. So, I mean, given his low blood pressure, his hypotension, you would suspect that there would be an increased heart rate, especially with pain, things like that. He should have a higher heart rate than he does. Mm-hmm. It's not bradycardic, so it doesn't necessarily trigger any alarm bells yet. You're like, oh, heart rate is 70. You're more just focused on that blood pressure. But had we taken a step back and actually looked at in the lens of neurogenic shock, you could see that there's something going on here.
Yeah, I agree. Tell me some things that you're considering as you have like multiple types of shock that you're trying to figure out which one's causing what and trying different interventions. What are some interventions that we could potentially make for a neurogenic, or I mean, really, we're talking about a distributive type of shock?
Yeah, absolutely. So distributive, an issue of the blood getting from the heart to the organs. So you're just trying to increase that tone of your veins. So so yeah, a vasoactive med. So we could do levofed. Specifically, if they're bradycardic and you're wanting to increase that heart rate anyway, you wouldn't mind epinephrine. Get a little bit of the inotropy effect, chronotropy effect. So yeah, those are kind of your two big ones. Whereas typically in a trauma with blood loss, you're not trying to do those vasoactive meds. You're trying just to replace those fluids.
Yeah, so in a hypovolemia, we want to replace what we lost. Maybe it was the fluid component, maybe it was blood itself, and we want to replace that with blood. In the obstruction, we tried to decompress. In this case, we are looking at a distributive cause that we believe is taking place, and a vasopressor may be something that would help us out as well. Now, I do want to go back here on these vitals and look at a couple of other things. We did see a pressure come back a little bit. Was there any explanation for that?
I'm trying to think of, I think we had just needled him between the first and second pressure. So like we had needled him right at that 1321, and we were on our way to the helicopter at that 1323.
Okay. So we saw some positive response. Now we give 75 micrograms of fentanyl here, and all of a sudden we see a pressure of 56 over 35, and I'm anticipating the emails coming already. I'm going to cite a study that is a pretty large study out of Canada with a flight service analyzing the hemodynamic stability of fentanyl. I don't believe that that's what's taking place. What do you think is happening here at this time here at 1328?
Yeah, so I think he's finally going into that decompensated shock. So now the question is decompensated shock from the distributive neurogenic, or is it decompensated from the hypotension or hypovolemia?
So let's take a look at the remaining course of your time with him. We saw these vitals. I'm sorry, we saw these vitals here. Just walk me through what's taking place at various times.
Yeah, so let's pick up from the 1323, he was screaming out. We saw the blood pressure was definitely compensated, so we treated his pain. You mentioned that there's the study that showed, and I was not concerned that 70 mics of fent was going to tank this guy. So what we see at 1328 is that that segue from that ramp up, that fire diagram that you showed of where it really starts escalating and he goes into that uncompensated shock. So his blood pressure just tanks. So we started with treating for hypovolemic shock. So we started some blood, and that had good effect. As you can see at 1331, his heart rate is still at 73, blood pressure 106 over 63.
Yeah, we're right here. Went from this 56 to 35. Blood initiated, all of a sudden we're 106 over 63. You liked that. That made you feel nice.
Definitely a step in the right direction anyway.
Okay. Yeah.
1335, not a major change. You know, you'd hope that it would continue to get better, and things are kind of tapering off. His heart rate's increasing a little bit, blood pressure decreasing a little bit, kind of still leading us down this hypovolemic shock. And then at 1340, he just starts tanking again, despite the fact that the blood was going in. So we went ahead and did a push dose pressor of Neo, started a levo drip. We're still not exactly sure. We think there's, we're starting to kind of lean more towards that neurogenic shock as his biggest problem, because you would still, again, suspect a heart rate greater than 83. And then at 13, yeah. And then at 1342, his heart rate goes down to 68, and that's when we're like, oh, he's definitely a neurogenic shock. We're titrating that levo up. His blood pressure is just tanking, and that's when we landed, and we're on the helipad on the way to the OR. And then at 1344 is that last set of vitals, that heart rate of 45, and that's when it's looking really bad. Of like, oh, he is in full-on neurogenic shock. There's no compensatory mechanism taking place. His heart is just completely begging down. Yeah.
So, if I were to summarize this, what I'm kind of seeing is that we treated that obstructive shock here. We got some response, but then re-identified now that maybe we have a hypovolemic situation. Treated that, got a positive response, and all of a sudden now decided it appears that we possibly have a distributive situation with our neurogenic shock. Treated it and delivered to the trauma surgeon alive and a potentially viable patient. I look at all of this and I say, very well done. It seems like to me like you guys did a great job. What do you know about his outcome? How did he end up?
Yeah, so you saw treatment-wise, he never needed intubated, got a chest tube, was in the ICU. I work in the ICU too, so was able to follow up a little bit on him. He remained paralyzed from the nipple line down. Got sensation back in his hand, or he always had sensation back in his arms. He got movement back in his arms. So
well, good. Well, good.
And lived, yeah. And so he's still living today. Yeah.
So this was a complicated case. You guys did a fantastic job in managing this patient. Tell me some of your major takeaways that you would share with somebody else who found themselves as a medic in a similar situation.
Yeah, so we briefly touched on that needle placement. A good method is just putting your hand and just going right below those forefingers, because again, going up a little high is not going to hurt you in that scenario. We kind of shortchanged. We were quick to get him to the helicopter, so we just drilled one IO, and we probably should have done a second IO, so that way we could have been treating both shock simultaneously. So we could have been putting that blood, putting that fluid back in him, and getting those vasoactive meds in him as well. So just a little bit more time on the front end would have definitely helped us from scrambling on the back end.
Okay, excellent. I have to say, by and large, I think you guys did a great job. I think this is an amazing case that we can all learn from. I hope everybody watching learned something. I know I have learned something in participating in hosting you, and want to thank you for being here. And I hope you run some more interesting calls and bring them back for us.
Absolutely.
All right.
Thanks so much.
Thank you. I hope you enjoyed the case study that we reviewed today. If you are an EMS provider and you have a call that you think others would benefit from hearing about, please reach out to me. I would love to help you share your experiences with others. The calls that we're looking for do not necessarily need to be rare or unique, and your performance on these calls don't necessarily need to be perfect either. The goal in this series is to all learn from each other's experiences in order to provide the best patient care that we can.